time. Again, another exciting session on ischemic and interventional heart disease. And who better to chair it than Dr. Vijan sir and Dr. Samir Pagat sir. So I ask them to please open proceedings.
Can I call upon Nagesh Wagmari, please, to talk to us on shock classification, role of IABP, Impela, and ECMO, when to use and how? Nagesh.
Yeah. Good evening. Thank you, AOC, for this opportunity. Cardiogenic shock is the last frontier where we are taking all the efforts, but still the outcomes are unpredictable. We need to know about many advances that are happening in daily life, which are adding value to the treatment we offer nowadays for the cardiogenic shock patient. I'll stick to the classification and the MCS part. So we'll go through it quickly. What is cardiogenic shock, how serious it is, what causes it, how to identify and how to treat. So basically it is a congestion and inadequate tissue perfusion, which is because of the cardiac insufficiency, and it leads to multi-organ dysfunction. So it is a multi-organ disorder, and that's the reason patient has a very high risk of death in this disorder. And this one slide tells us about the mortality. So all shocks lead to mortality to the tune of 60%. LV failure is 59, whatever the etiology. If there is a mechanical complication, the mortality is very high to the tune of more than 90%. So even tamponade has a high risk outcomes if not attended to. It's a major clinical problem with high rates of in-hospital and deaths within 1 month of discharge. The mortality is not changed much in last 3 decades, but fortunately the incidence of cardiogenic shock has gone down to 5 to 10% as compared to what it was 3 decades back. This is because of improving awareness about the lifestyle, improving treatment of the diseases at early stage, but a patient once lands up in cardiogenic shock, the mortality is very high. So there is a piecemeal necrosis with marginal extension in case of infarct, and once the more than 40% of the LV mass volume is affected, patient ends up in the cardiogenic shock. So this is a death spiral of CS, where it is started with infarction, there is a dysfunction, systolic as well as diastolic, there is reduced cardiac output, reduced stroke volume, hypotension, which affects the coronary perfusion pressure, further aggravates the ischemia. There is an increased end diastolic pressure of the LV, hypoxemia. So revascularization can relieve the ischemia and lead to improved survival, but there are caveats to it. We have to be timely when we are acting. There are 80% of the cases are ischemic, rest 20% are non-ischemic, maybe peripartum cardiomyopathy, myocarditis, stress cardiomyopathy, mechanical defects of AMI, and non-ischemic LV dysfunction. So there are patterns of non-ischemic cardiomyopathies, Takotsubo, mid-ventricular, a lot of variants are there, and there are well-described pathologies. There are emotional stress as well as physical stress, which causes catecholamine surge, leading to a lot of changes within the myocardial cells, leading to dysfunction. So how we identify shock? When a BP or the mean arterial pressure is falling, when the systolic BP is below 80 to 90 and there is a drop of MAP by more than 30, cardiac index without support is below 1.8 or with supports below 2.2 liters per minute per millimeter square, when the end diastolic pressure of RV is more than 10 or LV more than 18, and along with that there is evidence of hypoperfusion of the organs like altered mental status, decreased urine output or acute kidney injury, cold clammy peripheries, shock liver, lactic acidosis. So these are the two important grading of severity or classes of cardiogenic shock based on the clinical findings and the hemodynamic data. This is important slide, I will not rush through it. So there is emergence of new parameters called PAPI and cardiac power output. PAPI is pulmonary artery pulsatility index. So we have to look at hemodynamics when we want to define what is the issue, whether there is a LV failure, there is a RV failure, or there is a biventricular failure. And looking at all the parameters, we can easily clinch the diagnosis. We have to look for the RA mean pressure, RV end diastolic pressure, pulmonary artery pressures, pulmonary capillary wedge pressure, the PAPI, that is pulmonary artery pulsatility index, cardiac index, and the cardiac power output. When there is a AMI without LVF, that is the at-risk patient, all the parameters are as close to the normal parameters. Once there is LV end diastolic pressure, the PCWP increases, it is more than 18, the cardiac output is usually below 2 and cardiac power output is less than 0.6. In case of RV event, if there is RVMI, the PAPI falls, it is below 1. This is very important to differentiate RV induced LV failure, and PCWP remains on lower side. In case of tamponade, there will be increased RV end diastolic pressure, there will be PAPI which is below 1. So these are important hemodynamic data which will guide us to come to a conclusion. Regarding classification, historically we have studied many types of classification for cardiogenic shock, but what is more important is the classification where we can identify the stage and its progression. It can be dynamic to and fro. Sky shock stage classification is proposed in 2019. It is a simple, unified and standardized vocabulary of the definition as well as identifying the shock stage, and it is the widely adopted one. This is the pyramid of cardiogenic shock. This is very important and we should all follow, the world is following this commonly, even majority of the trials are using this classification. A is at risk, where there is a reason to develop heart failure, but there is no heart failure, there is no decompensation. AMI, large AMI, but cardiac perfusion is output and perfusion is maintained. B is beginning of the shock. Patient has started developing hypotension, there is tachycardia, abnormal systemic hemodynamics. C is classic shock, where patient has evidence of hypoperfusion, requires pharmacological or mechanical support. Hypotension is usually present in C. Now, when we talk about management, we should act at a stage even at beginning, and we should not let the shock stage progress beyond classic. D is the deteriorating. The patient who has clinical evidence of shock is worsening or failing to improve despite of escalation of the therapy. What therapy? We'll talk in subsequent slide. And E is the extremis. The patient is in refractory phase of the shock and it is actually impending collapse of the circulation. And there are modifiers, CA, the cardiac arrest, whether the patient has received CPR for CA or no. So each stage is indication of severity and predicts mortality. It correlates with all etiological subgroups. The progression across the continuum is dynamic progress, and it can reverse also based on our intervention. The lactate levels are important, but they may not be completely associated with the hemodynamics. So this is how the mortality varies with the sky shock stage of the cardiogenic shock. Starting from A to E, we can see the mortality is ranging from less than 10% to more than 60%. And these are the definitions. What is hypotension is defined here in the shock stage classification. Then hypoperfusion, where people are using lactate levels, urine output, and the rise in creatinine. Deterioration is defined within 24 hours, what the need of inotrope, whether is going up or no, and there are many indices and the definition of the refractory shock. So, as we can see, whether the patient has got a cardiac arrest episode or no, based on that, again, the mortality varies in the hospital for a cardiogenic shock patient. It progressively increases with the stage of shock. And these are the etiologically based mortality rates. We can see the ischemic event, the ACS group carries the highest mortality to the tune of more than 80%, and as compared to non-ischemic heart failure. So again, this also correlates with the stage, the odds ratio of mortality. So how we treat it? So we have to decide what are the precipitating factors, whether it is cardiac or non-cardiac issue, and based on that, we have to start treatment. We have to identify the triggers for the cardiac, whether it is ischemia, whether it is diastolic dysfunction, arrhythmias, or valvular heart disease. We are seeing a lot of heart failure because of severe aortic stenosis, which is remaining neglected for a long-standing period for the patients. Non-cardiac triggers may be poorly controlled hypertension, low hemoglobin, thyroid issues, non-compliance to the medicines, excessive salt or fluid intake, worsening kidney function. So we have to identify the triggers, act on that, and achieve a good result for the patient. The objective of the management are basically three primary objectives. We have to support the circulation, which we do by using vasopressors and the inotropic supports. What we fail to do is the second objective, which is the ventricular unloading. See, we have seen or we have done a lot of PAMIs for acute MI, especially enteral MI patients. Within 3 hours, within 6 hours of symptom onset, but the patient has not done well. Either there is mortality or the EF remains low. Why so? Because we failed to understand the concept of ventricular unloading, where the perfusion pressure is really low, and despite of opening the blood vessel, the muscles become non-viable, and we have to of course achieve the coronary perfusion. So these are the 3 primary objectives when we are talking about treating AMI CS patients. So this is what I mean. Circulatory support, we have to maintain a good mean arterial pressure and make sure that the lactate is falling and the creat is stable. We have to give support to the ventricles, whether it is LV or RV. In case of inferior MI, we have seen RV failure leading to cardiogenic shock, and we have to make sure we are supporting to maintain a good end systolic pressure and less end diastolic pressures, so that the perfusion pressure is better. We have to treat the ventricular tachycardias and make sure that the parameters are measured and taken help for monitoring the progress. And coronary perfusion is achieved so that mean arterial pressure maintains in a good level. So what is important here is hemodynamic problem is not translated to the hemometabolic problem. Once it is hemometabolic problem, it is in unpredictable area, we may not control completely. The limitations of the conventional therapy, mortality remains high with increasing need for the inotropes, and we have seen in the IABP shock 2 trial, there is no mortality benefit with the IABP. So this is what is the new paradigm or the new protocol. We have to look for the systolic BP, which is the diagnosis and clinical assessment of the shock, evidence of the end organ perfusion and the lactate level at the entry point, at the admission level, then transfer the patient based on the SCAI stage of the shock. We have to take the patient to cath lab if it is ischemic or the AMI related event. We have to do angio with supports, maintaining proper PCWP and end diastolic pressure. So based on the cardiac arrest and severe respiratory failure, if there is a respiratory failure and hypoxia, that is the only indication where we can consider putting VA ECMO. Otherwise, we have to look at the cardiac index, PCWP, cardiac power output, PAPI, and based on that decide whether there is RV failure, LV failure or biventricular failure. In case of RV failure, there is isolated Impela RP indicated, or we can consider tandem heart. Here is the need of our cardiac surgeon colleagues. For LV failure, we need Impela in various powers or tandem heart. In case of biventricular failure, it is a combination of Impela RP plus LVAD, percutaneous LVAD, or VA ECMO if there is a hypoxia. So these are the various supports for the right ventricle. They have individual benefits.
Nagesh, you might like to wind up.
Yeah, well, 2 slides only. So we have to understand the ECMO, a lot of people talk about it, but when we are dealing with cardiogenic shock, because of LV dysfunction, it increases the afterload of the LV, and it is not a good thing for a failing heart. It causes permanent damage, so ultimately we have to unload the LV. So LV unloading happens with Impela. This is the pressure volume loop. We can see the end diastolic pressures as well as the is reducing and the volume is improving here. That improves the cardiac power output, preserves the myocardium. I'll go to last slide. So Impela has shown improved survival vis-a-vis IABP as well as ECMO for cardiogenic shock. So we need a heart team approach where there is an interventional cardiologist, a cardiac surgeon who is expert in ECMO and transplant and LVAD. We need advanced heart failure. We need intensivist also, because we need to take care of the nutrition, infection prevention, DVT prevention, lot of things when the patient is in ICU. So to summarize, CS is a serious entity with high risk of mortality. We need to have a shock teams and protocols in place. Coronary revascularization is necessary but not enough. We need to understand the concept of LV unloading for good recovery of the myocardium. Right heart cath becomes necessary when we are dealing with a refractory shock and need to be well versed with all the MCS devices. Thank you.